Again, you can review this in the Minnesota film, but we'll quickly review a few points that may help. In order to easily locate the ovaries, put the uterus back where you found it. That is, don't try to palpate ovaries while the uterus is in the retracted position. You'll likely get disoriented. The ovaries lie in the broad ligament on either side of the body or bifurcation of the uterus. Simply slide your hand down the cervix to the body and move to one side or the other. In nearly all cases, you'll feel the distinct lump that is the ovary. Gently slide your hand under it, opening a space between your middle and ring fingers in which to cradle the ovary. Now you're free to palpate the surface with the thumb and index finger. In order to more easily differentiate ovarian structures, consider the following. Follicles are essentially a vesicle. That is, if you envision a fluid-filled blister, you have a good idea of what you're palpating. In contrast, the word corpus, as in corpus luteum, means body. That is, instead of fluid, the corpus luteum contains glandular tissue, which often has a liver-like consistency. Most corpora lutea have a papilla, or crown-like projection, above the surface of the ovary. This projection and its liver-like firmness generally make this CL easy to diagnose. Note that the entire ovary is distorted from its normal almond shape. Some CLs, though, have no papilla. In these cases, it is useful to remember that the papilla, when it is present, is only the tip of the iceberg. The majority of its substance is within the ovary. Therefore, deep palpation of the ovary will most often reveal a distinct line of demarcation between the bottom of the CL and the stroma of the remaining ovary. This waistline, or equator, is usually palpable with the tip of the thumb. Note again that even without a papilla, the shape of the ovary is distorted from its normal outline. Ovarian cysts are palpable as overly large follicles. For sake of simplicity, we'll define a cyst as any fluid-filled blister of more than 20 to 25 millimeters diameter. The ovarian bursa, although not routinely palpated, can be examined in cases of repeat breeder cows who cycle normally but who do not conceive. To examine them, pick up the ovary as before and hold it in the thumb and index finger, while the other fingers slide down the lateral side of the mesovarium and broad ligament. Usually, the fingers will hook into the bursa, which can then be inverted, and its oviduct palpated with the fingers and thumb. Although they are present much earlier, most palpators will first recognize them at this stage. Some texts list an order of increasing fetal age based on the size of the palpated placentome. While this may be the only finding to hang your hat on, remember that this method is fraught with inaccuracies because there is considerable variation of placentome size within the same uterus. Therefore, two palpators may find two different placentomes and thus assign different ages to the same pregnancy. The finding of fremitus in either or both middle uterine arteries is, with rare exceptions, consistent with advanced pregnancy, that is, beyond 120 days. Fremitus will occur in the artery supplying the pregnant horn only until about the 7th month, when both arteries may have fremitus, although the pregnant side's artery will be larger. Finding of fremitus in both middle uterine arteries when they are symmetrical is indicative of twin pregnancy. Palpation of the ovaries of pregnant cows is not often necessary, except occasionally to locate the side on which the ovulation and the pregnancy exist. This would only be necessary if the vesicle or the fetus itself was not palpated, and a secondary sign of pregnancy, such as a membrane slip or placentome palpation, was used to determine pregnancy. The CL is located ipsilateral to the pregnancy in nearly all cases in cattle. Exceptions are extremely unusual. Often, the CL of pregnancy will have no palpable papilla and will be quite soft due to remodeling and vascularization. In these cases, beginning palpators are often tempted to diagnose a cyst and may even attempt to rupture it. The disastrous consequences of such a mistake would be easily avoided if the uterus is palpated first, before the ovaries. The finding of a pregnancy would dictate that ovaries be treated gently. In general, the larger, softer of the two ovaries is the one containing the CL of pregnancy. Endometritis. This will palpate as a thickened uterus with doughy tone. A discharge may or may not be seen on vaginal examination. Pyometra. This can easily be confused with pregnancy. The uterus is heavy and fluid-filled, but does not have a membrane slip, nor placentomes, nor a palpable fetus. Almost invariably, a pyometra will be associated with a corpus luteum. That is, the uterus will be under continual luteal influence. There may or may not be a discharge from the cervix or vagina, so that speculum exam can easily miss a true pyometra. It is necessary, therefore, to be able to diagnose this condition rectally. The palpation of a distended, fluid-filled, flaccid uterus without a membrane slip and in the presence of a CL should tentatively indicate a pyometra. Uterine adhesions. Depending on severity, these may or may not be palpable. Following inflammatory disease of the uterus, fibrin tags may develop on the serosal surface of the uterus. These may subsequently organize to permanent fibrous adhesions. Some are severe enough to adhere the uterus to surrounding structures, most often the greater omentum. Minor adhesions, where a portion of the uterine horn is adhered to an opposed portion of the same horn, are more subtle and may be missed. Uterine abscesses. These are palpable, firm